Hi, my name is Whitney Lowe and I'd like to welcome you to the second DVD in my orthopedic massage series. The lower extremities are the limbs of locomotion, so they take quite a pounding from repetitive loads as well as other activities. Lower extremity pain and injury conditions are common in numerous occupational activities. Injuries result from repetitive motions, lifting, moving, or other mechanical challenges. Recreational activities also put stress loads on lower extremity tissues and can create biomechanical challenges that produce soft tissue pathologies. The soft tissues of the thigh, knee, leg, and foot can be overwhelmed from these loads, so massage therapy is a key treatment for orthopedic disorders affecting this region. Knee ligament injuries are relatively common, but the anterior and posterior cruciate ligaments are deep in the knee and therefore inaccessible to massage. The next 4 tests will help you be able to rule out injuries to these ligaments. The anterior drawer test evaluates the integrity of the anterior cruciate ligament. Clients showing signs of injury to these ligaments should be referred to an orthopedist. The anterior cruciate ligament, or ACL, is one of the most frequently injured tissues in acute knee injuries. It spans between the anterior aspect of the tibial plateau to the posterior side of the femur between the femoral condyles. The ACL's primary function is to prevent forward shifting of the tibia in relation to the femur. For example, when an individual suddenly stops when running or lands from a jump, there is a strong forward force on the tibia. The ACL's job is to absorb some of this force. Begin with your client in a supine position with the hip flexed and the knee flexed and the foot flat on the table. Anchor the client's foot underneath your thigh so it stabilizes the lower extremity. Place both hands behind the proximal end of the tibia with your fingertips and place your thumbs near the top edge of the tibial plateau. Once in this position, take up the slack in the muscles on the back side of the tibia and give a firm pull towards yourself and identify if there is any pain, mushy end feel, or forward movement of the tibia as you give that forward tug. Watch the top edge of the tibial plateau to see if there is any forward translation in this direction. It's not going to be a great deal if it is visible, but you'll feel the mushy end feel and you'll see a little bit of movement coming forward that way. If it does, this is indicative of potential injury to the anterior cruciate ligament. The Lachman test is considered the most accurate evaluation procedure to test the integrity of the anterior cruciate ligament. There are 2 main variations to this test. For the first one, place one hand underneath the proximal tibia, and the other hand is going to stabilize the distal femur placed directly on top of it. Give a firm upward pull with the hand that's on the tibia, and identify if there is any pain, mushy end feel, or forward movement of the tibia when giving that firm upward pull. It won't be a great deal, but just a sense of mushy end feel or a little bit of forward translation in this movement. This test is also performed with the knee in a slight degree of flexion, again stabilizing the distal femur with one hand, the other hand wrapped around the tibia, and giving a nice firm upward pull, trying to identify if there is any pain, mushy end feel, or forward translation of the tibia. Sometimes this test is also performed in the second variation, which some practitioners find to be an easier position. That's performed with the client at the end of the table. Kim, if you will, come sit to the end of the table here. With the client in this position, have them reach down and place both hands on the distal femur to hold it stabilized in position. Grasp the client's foot between your legs so that it keeps the knee in a partial flexion. With your fingertips wrapped behind, this is somewhat similar to the anterior drawer test position, and the thumbs placed on the upper part of the tibial plateau. Give a nice firm upward pull again on the tibia, and notice if there is any pain that the client reports, a mushy end feel, or any forward movement of the tibia indicating potential injury to the anterior cruciate ligament. The posterior drawer test evaluates the integrity of the posterior cruciate ligament in the knee. This is another test that allows you to rule out a more serious injury that would need referral. The word cruciate means cross, and the anterior and posterior cruciate ligaments cross inside the knee joint. the PCL is injured much less often than its counterpart, the ACL. The PCL spans between the posterior aspect of the tibia and the medial condyle of the femur. Its primary function is to prevent posterior shifting of the tibia in relation to the femur. Begin with your client in a supine position and bring the hip and leg up into a position of knee flexion and hip flexion. Anchor the client's foot underneath your thigh to stabilize the lower extremity. With both hands, grasp back behind the proximal tibia and place your thumbs near the top edge of the tibial plateau. With this position, give a firm, posteriorly directed push this direction back on the tibia, and notice if there is any mushy infill, visible posterior movement of the tibia, or if the client reports pain with that motion that's the same pain they've been reporting. Any posterior movement or mushy infill that's felt with that good firm push could be indicative of injury to the posterior cruciate ligament. The gravity drawer is also a visual examination for PCL dysfunction. For this test, bring both clients' hips and knees into a flexed position so the feet are flat on the table. In this position, make sure to line up the back side of the heels so that they're right even with each other. This is a visual examination, so you want to look straight across the front side of the tibial plateau, or the top edge of the tibial tuberosity on each side. If one side drops farther back than the other, this is indicative of damage and weakness in the PCL, or posterior cruciate ligament. Another variation of this test, sometimes called the Godfrey test, can be performed by bringing the client's hip and knee up into a flexed position and keeping both tibia horizontal to the treatment table. From this position, again, bend down to examine the top edge of the tibial tuberosity and see if there is any unevenness or posterior drop in the tibial tuberosity. From this position, any indication or drop in a posterior direction would be an indicator of damage to the posterior cruciate ligament. In these next two tests, massage is appropriate for treating the tissues involved. The Valgus stress test examines the integrity of the medial collateral ligament of the knee. The medial collateral ligament is also called the tibial collateral ligament because of its attachment to the tibia. It spans from the medial condyle of the femur above to the medial surface of the proximal tibia below. It's most commonly injured with an excess valgus force to the knee. A valgus force is one that forces the knee in a medial direction. Begin with your client in a supine position. Place your hand on the lateral side of the knee and the other hand down near the distal part of the leg so that you can offer stabilization. With this hand, place a valgus force pushing straight across the middle of the knee. It's very important with the hand position that the middle of your palm is right over the middle section of the joint line. If your hand is too far above or too far below, you won't get an accurate determination of laxity in the ligamentous tissues. So with my hand in position directly over the joint line, the other one stabilizing the distal leg, I'll push straight across with a good firm push, and she's got a nice, firm, stiff feeling knee, which is indicative of a healthy ligament. If it was damaged, you may have sort of a mushy infill, there might be pain, or you might even see a bit of joint gapping on the medial side of the knee. This test is also performed in a position with the knee in slight flexion. When the knee is in slight flexion, the anterior cruciate ligament is not able to resist some of the valgus forces that you're applying with your hand. For that reason, it's considered a little bit more effective because it isolates the medial collateral ligament more effectively than does the position of straight knee extension. Again, a mushy infill, visible joint gapping, or any significant pain reported on the medial side of the knee could be indicative of medial collateral ligament injury. The Varus stress test examines for the integrity of the lateral collateral ligament of the knee. Injuries to the lateral collateral ligament are not anywhere near as common as those to the medial collateral ligament. The lateral collateral ligament is also called the fibular collateral ligament because of its attachments to the fibula. It spans from the lateral epicondyle of the femur above to the head of the fibula below. It is most commonly injured with an excessive varus force to the knee. A varus force is one that forces the knee in a lateral direction. For the varus stress test, the client's position is the same and your hands are in close to the same position as you did for the valgus stress test. Place one hand on the medial side of the knee and the other hand on the distal side of the client's leg, or you can even brace the client's foot against your body. Once in this position, give a nice firm varus force, which is a force going from the inside toward the lateral direction. Just like in our previous test, the hand position is very important. The middle of your palm should be resting right over the middle of the joint line. It should not be too far above or too far below the knee, or you won't get an accurate reading. With this varus force that's applied out here, notice if there is any visible joint gapping, any mushy end feel when you perform this, or if it produces lateral knee pain. As with the valgus stress test, it's slightly more accurate if it's performed in a slightly flexed position. So put that knee in a slightly flexed position and push across with the varus force. This takes the anterior cruciate ligament out of the equation so that you get a more accurate read of the lateral collateral ligament and seeing if it is injured. The Clark sign is used to assess patellar tracking problems. While not considered highly accurate, this test is still useful for evaluating patellofemoral function. During flexion and extension of the knee, the patella must be able to slide superiorly and inferiorly between the two femoral condyles. There is a ridge on the underside of the patella that fits between the femoral condyles. If there are unequal forces pulling on the patella from the tissues that connect with the patellar retinaculum, the patella will not move correctly in this channel. Dysfunctional patellofemoral mechanics are called tracking disorders and can cause serious knee pain. With your client in a supine position, take the hand and place it just over the suprapatellar tendon at the top edge, or what's often called the superior pole of the patella. Take the webbing between the thumb and fingers and place that right over the superior pole of the patella and give a moderate downward pressure here. I'm going to instruct Kim to slowly contract those quadricep muscles while I hold the pressure down on here. Now, it's important with this test to have the client do this slowly, because sometimes if they do it too quickly, it can cause a great pain sensation all of a sudden. So I'm going to press down on here, and Kim, just slowly contract those quadriceps, and if you feel pain at any point, you can stop right there. That's good. And now relax. Another way to do this test is to use different levels of pressure to begin with. So start with just a light pressure, have them slowly contract the quadriceps. If that works, give a little bit more pressure. Let's try that once again. Slowly contract there. And then do it a final time with a good firm pressure directly over there. Any pain that's felt in the anterior knee region when this is performed could be indicative of patellar tracking disorders. The next two tests evaluate for iliotibial band irritation near the lateral epicondyle of the femur. On the lateral side of the knee, the iliotibial band courses over the lateral epicondyle of the femur. At its superior end, the gluteus maximus and tensor fasciae lata pull on it to help stabilize the knee. During flexion and extension of the knee, excess friction on the iliotibial band could result. Excess friction leads to iliotibial band degeneration and lateral knee pain. For this test, have the client in a side-lying position. Kim, let me roll over onto your left side and get somewhat diagonal on the table. You want to have your client in a diagonal position so the torso can be in a good straight line with where their leg is going to end up. So we'll bring the client's leg into a position of abduction and hyperextension, and make sure to keep the pelvis as vertical as possible, putting them in this position. From here, slowly lower the client's leg down, and you want to just do a visual examination and see where the client's leg ends up. If it ends up at a position below horizontal, that's considered within normal parameters. Even, however, if it ended up here, if I took my hand out from underneath her and her leg stayed here, this would still be considered tightness in the iliotibial band, even though it is below horizontal. However, in a case, if I bring her leg up here and let go of my hand and the leg stayed in this position, this would certainly be indicative of tightness in the iliotibial band. The iliotibial band has attachments, as we mentioned, from the gluteus maximus and tensor fasciae lata muscles up here. If the band is very tight, it may cause excess friction over the lateral epicondyle on the lateral side of the knee. So watch for any significant tightness in here that might lead to excess friction causing lateral knee pain. The Noble compression test evaluates for tenderness and irritation of the iliotibial band where it crosses the femoral epicondyle. Excessive tenderness in this region would indicate a likelihood of adverse iliotibial band friction. With our client in a supine position, bring her leg up into a position of hip flexion and knee flexion. The lateral epicondyle is the prominent bony landmark just on the lateral side of the knee. Place both thumbs just superior to the lateral epicondyle of the femur so that you press on the iliotibial band here. And from this position, have the client fully extend the knee and bring it back down into flexion. And again, an extension and bring it back down. Any pain that's reproduced on the lateral side of the knee during that motion, especially if it is about at 20 degrees of flexion, could be indicative of excess friction causing irritation of the iliotibial band over the lateral epicondyle of the femur. The Apley's compression and distraction tests are primarily designed to differentiate between ligamentous damage and meniscal damage inside the knee. Meniscal damage will need to be referred to an orthopedist, but some ligamentous injuries can be treated with massage. The meniscus is composed of two semicircular cartilage discs that sit on top of the tibial plateau. The medial meniscus is slightly larger and more open than the lateral meniscus. There is very little innervation to portions of the meniscus, so in some cases significant tears or damage can occur to the meniscus before the client feels it as pain. There are two parts to the Apley's compression and distraction test. The compression test is first. Bring the client's knee up into a position of flexion. Have one hand on the distal leg and the other hand on the bottom surface of the client's foot. Press straight down so you're pressing the tibia against the femoral condyles and give a twist or rotational movement to the tibia. Most people don't realize that the knee is capable of some degree of rotation when it's in a flexed position. When it's in extension, it can't rotate because the ligaments are taut inside the knee. But from this position, you can get rotation in the tibia. When you're performing this test, make sure that the rotation comes from the tibia and not from turning or rotating the ankle. So push down and twist to the full range on each side. Find out from the client if there is any pain or popping or clicking sensations felt as you do this motion. The second part of this test is the distraction test. For the distraction test, place your knee on the back of the client's thigh to hold the femur firmly to the table. Both hands are now grasping the distal tibia and will pull upward on it and turn and rotate in this position. Here we want to ask our client if there is any pain or discomfort or if there's any popping or clicking sensations felt as you pull, lift, and turn to each side. Just as with the compression test, make sure you're not twisting or turning the ankle as you do this, but are in fact turning the tibia so that the rotation is at the knee. If there's pain felt during compression and distraction, this is most likely an indication of ligamentous injury. If pain is only felt during the compression test when you're pushing down on the meniscus, but it's not felt during the distraction test where the pressure is off the meniscus, then this is more indicative of meniscal injury. It's difficult to evaluate the meniscus with physical examination as it is deep inside the knee joint. However, the McMurray's test is considered one of the more accurate ways to evaluate suspected meniscal involvement. This is another test that will rule out more serious meniscal damage that might need to be referred to an orthopedist. Begin by bringing the client's knee into a fully flexed position. Tuck the heel as close in as you can with the knee fully flexed and your hand cupping underneath the client's leg. Your fingertips are on the medial joint line, your thumb is on the lateral joint line. With the foot laterally rotated, simply bring the client's leg out into extension and come back up. Do that again. Come back up. Pay attention during each of those movements. Identify if there is any sensation of clicking or popping underneath your fingertips on the medial joint line. With the foot laterally rotated, you're emphasizing the medial meniscus. You can do that same thing again by turning the foot into medial rotation, which emphasizes the lateral meniscus. So this time pay attention to the sensation underneath your thumb. Again, with the foot fully touched to begin, start this position. Slowly bring the client's leg out into extension and come back up. We'll do it twice just to be sure, paying attention to any sensation, popping, clicking, or any pain that is felt in that motion. Any pain or discomfort that's felt in these positions or popping or clicking sensations along the joint line could be indicative of meniscal damage.